Question 1. Governance review demonstrates that a pediatric patient presents with a history of prematurity, bronchopulmonary dysplasia, and a documented inability to achieve adequate caloric intake via oral feeding due to significant dysphagia and recurrent aspiration. The child has also experienced a recent 10% unintentional weight loss over a 2-week period. Which of the following approaches best aligns with the established indications for initiating enteral nutrition in this pediatric patient, adhering strictly to U.S. regulatory frameworks and professional guidelines for pediatric nutrition specialists? Option A. Continue to monitor oral intake and provide oral nutritional supplements, delaying enteral nutrition until oral intake completely ceases. Option B. Initiate enteral nutrition via nasogastric or orogastric tube to provide adequate caloric and protein intake, given the documented inability to meet oral needs, risk of aspiration, and evidence of malnutrition. Option C. Recommend immediate initiation of parenteral nutrition due to the complexity of the medical conditions and the presence of dysphagia. Option D. Focus solely on managing the bronchopulmonary dysplasia, assuming nutritional needs will be met once respiratory status improves. The correct answer is B. Initiate enteral nutrition via nasogastric or orogastric tube to provide adequate caloric and protein intake, given the documented inability to meet oral needs, risk of aspiration, and evidence of malnutrition. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the pediatric nutrition specialist to navigate complex clinical indicators and potential contraindications for enteral nutrition in a vulnerable pediatric population. The decision to initiate enteral nutrition is critical, impacting growth, development, and overall health outcomes. Misjudgment can lead to delayed intervention, inadequate nutritional support, or iatrogenic complications. The specialist must balance the immediate need for nutritional support with the potential risks and benefits, considering the child's specific medical condition and the available evidence-based guidelines. Correct approach analysis. The correct approach involves a comprehensive assessment of the child's gastrointestinal function, nutritional status, and underlying medical condition to determine if enteral nutrition is indicated and safe. This aligns with the principles of evidence-based practice and patient-centered care, as mandated by professional standards and ethical guidelines for pediatric nutrition specialists. The focus is on identifying specific clinical criteria that necessitate enteral support, such as inability to meet oral intake needs due to malabsorption, increased metabolic demands, or impaired swallowing, while also considering contraindications like severe gastrointestinal dysmotility or obstruction. This approach ensures that enteral nutrition is initiated appropriately and safely, maximizing its therapeutic benefit. Incorrect approach is analysis. Initiating enteral nutrition solely based on a general diagnosis of failure to thrive without a thorough assessment of gastrointestinal function and specific indications for enteral support is an ethical and regulatory failure. This approach bypasses the critical step of identifying the root cause of failure to thrive and whether enteral feeding is the most appropriate intervention. It risks providing unnecessary invasive support and delaying the investigation into other potential causes or more suitable interventions. Recommending parenteral nutrition as the first-line intervention for any child unable to achieve adequate oral intake, without first evaluating the potential for and safety of enteral nutrition, represents a significant regulatory and ethical lapse. Parenteral nutrition carries higher risks of complications, including infection and metabolic derangements, and is generally considered a second-line option when enteral routes are not feasible or sufficient. This approach fails to adhere to the established hierarchy of nutritional support and may expose the child to undue risks. Delaying the initiation of enteral nutrition until the child is severely malnourished and critically ill is a failure to provide timely and appropriate nutritional care. Professional guidelines emphasize early intervention to prevent severe malnutrition and its associated morbidities. This approach not only violates ethical obligations to provide optimal care, but also contravenes regulatory expectations for proactive nutritional management in pediatric patients at risk. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough patient assessment. This includes evaluating the child's medical history, current clinical status, nutritional intake, and gastrointestinal function. Next, They should consult relevant evidence-based guidelines and professional standards for pediatric nutrition support to identify specific indications and contraindications for enteral nutrition. This is followed by a risk-benefit analysis for the individual patient, considering the potential benefits of enteral nutrition against the risks of the chosen route and formula. Finally, the decision should be documented clearly, including the rationale, and the patient's response should be monitored closely, with adjustments made as needed. Question 2. Market research demonstrates that pediatric healthcare providers are increasingly utilizing nutritional biomarkers such as albumin, prealbumin, transferrin, and retinol-binding protein, RBP, to assess the nutritional status of children. A 7-year-old child presents with a history of poor appetite and a recent viral illness, showing slightly decreased levels of albumin and prealbumin. Which of the following approaches best reflects a comprehensive and evidence-based interpretation of these biomarkers in this clinical context? Option A. Assume that the decreased albumin and prealbumin levels are solely due to inadequate dietary protein intake, and recommend a high-protein diet without further investigation into other potential contributing factors. Option B. Interpret the decreased albumin and prealbumin levels as indicative of acute phase reactant response due to the recent viral illness, and recommend monitoring of growth parameters and dietary intake, considering other clinical factors before initiating significant nutritional interventions. Option C. Focus on the retinol-binding protein, RBP, as the most sensitive indicator of short-term nutritional status, and recommend a supplement, disregarding the albumin and prealbumin findings. Option D. Conclude that the child is significantly protein-energy malnourished and recommend immediate aggressive nutritional supplementation based solely on the decreased albumin and prealbumin levels. The correct answer is D. Conclude that the child is significantly protein-energy malnourished and recommend immediate aggressive nutritional supplementation based solely on the decreased albumin and prealbumin levels. Explanation: this scenario is professionally challenging because it requires a pediatric nutrition specialist to interpret complex biomarker data in the context of a specific clinical presentation, while adhering strictly to the established evidence base and professional guidelines relevant to the board's certified specialist in pediatric nutrition, CSP certification. The challenge lies in moving beyond simple data, reporting to a nuanced interpretation that informs clinical decision-making and patient care, ensuring that the chosen approach aligns with the highest standards of practice and regulatory compliance within the pediatric nutrition domain. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based interpretation of nutritional biomarkers within the broader clinical context of the child. This involves considering the limitations of individual biomarkers, understanding their dynamic nature, and integrating this information with other clinical data, e.g., dietary intake, growth parameters, medical history, to form a holistic assessment. This aligns with the CSP's mandate to provide expert, evidence-based nutritional care for pediatric populations, ensuring that interventions are appropriate, effective, and safe. Regulatory frameworks and professional guidelines for pediatric nutrition emphasize individualized care and the use of validated assessment tools and interpretations. An incorrect approach that solely relies on a single biomarker without considering its limitations or the overall clinical picture fails to meet the standards of comprehensive nutritional assessment. For instance, focusing solely on albumin as a marker of protein status can be misleading, as it is a negative acute phase reactant and can be affected by inflammation, hydration status, and liver function, rather than solely reflecting nutritional status. This would be a regulatory and ethical failure, as it could lead to misdiagnosis or inappropriate treatment recommendations, potentially harming the child. Another incorrect approach might involve extrapolating findings from adult populations to pediatric cases without considering age-specific physiological differences and reference ranges. Pediatric nutrition is a specialized field with unique considerations, and applying adult data without critical evaluation is a deviation from best practice and potentially a violation of professional guidelines that mandate age-appropriate assessments. A third incorrect approach could be to recommend aggressive nutritional interventions based on isolated biomarker values without confirming the findings through repeat testing or further clinical investigation. This demonstrates a lack of critical appraisal and could lead to overnutrition or unnecessary dietary restrictions, which are detrimental to pediatric growth and development. This represents a failure to adhere to the principle of evidence-based practice and patient safety, which are core tenets of the CSP certification. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review all available clinical data, including patient history, physical examination findings, growth charts, and laboratory results. 2. Interpret each nutritional biomarker in the context of the child's age, physiological state, and potential confounding factors. 3. Synthesize the information from multiple biomarkers and clinical data points to form a comprehensive nutritional assessment. 4. Consult relevant, up-to-date evidence-based guidelines and literature specific to pediatric nutrition. 5. Formulate a diagnosis and develop an individualized nutrition care plan, considering the limitations and dynamic nature of biomarkers. 6. Plan for follow-up and reevaluation to monitor the effectiveness of interventions and adjust the plan as needed. Question 3. Which approach would be most appropriate for a pediatric nutrition specialist when a parent expresses concern about their toddler's extremely limited food intake and resistance to trying new foods, exhibiting behaviors such as gagging on textures and refusing to sit at the table? Option A. Provide a generic list of healthy toddler foods and instruct the parent to offer these exclusively at every meal, regardless of the child's current preferences or reactions. Option B. Suggest implementing strict time limits for meals and removing all food from the table if the child does not eat within that time frame, focusing solely on behavioral consequences. Option C. Conduct a comprehensive feeding assessment, including a detailed dietary history, observation of mealtime interactions, and evaluation of the child's oral motor skills and sensory preferences to identify potential underlying causes before recommending interventions. Option D. Advise the parent to immediately restrict all preferred foods until the child agrees to eat a wider variety of items, believing this will create a stronger incentive to try new foods. The correct answer is C. Conduct a comprehensive feeding assessment, including a detailed dietary history, observation of mealtime interactions, and evaluation of the child's oral motor skills and sensory preferences to identify potential underlying causes before recommending interventions. Explanation. This scenario presents a professional challenge because assessing feeding practices and behaviors in pediatric nutrition requires a nuanced understanding of developmental stages, family dynamics, and potential underlying medical or behavioral issues. The specialist must navigate potential parental anxiety, cultural influences on feeding, and the child's individual temperament and sensory sensitivities. Careful judgment is required to differentiate typical developmental feeding challenges from those requiring intervention, ensuring recommendations are evidence-based, practical, and respectful of the family's context. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment that considers the child's developmental stage, the family's environment, and the child's specific feeding behaviors. This aligns with the ethical principles of beneficence and non-maleficence, ensuring interventions are tailored to the child's needs and do not inadvertently create new problems. It also reflects a commitment to evidence-based practice by seeking to understand the root causes of feeding difficulties before implementing strategies. This approach respects the family's autonomy and promotes collaborative goal setting, which is crucial for long-term success. An incorrect approach that focuses solely on restricting food options without a thorough assessment fails to address the potential underlying reasons for the child's behavior, such as sensory issues, anxiety, or a need for greater autonomy. This could lead to increased food aversion, nutritional deficiencies, and strained parent-child relationships, violating the principle of non-maleficence. It also risks oversimplifying a complex issue and may not be aligned with current pediatric feeding guidelines that emphasize a supportive and responsive feeding environment. Another incorrect approach that relies on generalized advice without considering the child's age and developmental stage is problematic. Pediatric nutrition is highly age-dependent, and recommendations suitable for an infant may be inappropriate or ineffective for a toddler or older child. This lack of specificity can lead to frustration for both the child and the parents, and may not address the unique challenges presented at different developmental milestones, potentially leading to suboptimal outcomes. A third incorrect approach that immediately suggests behavioral modification techniques without first understanding the child's sensory preferences or potential underlying medical conditions is premature. While behavioral strategies can be effective, they are most successful when integrated into a holistic plan that accounts for the child's sensory processing, oral motor skills, and any gastrointestinal discomfort. Implementing behavioral strategies in isolation might be ineffective or even counterproductive if the fundamental issues are not addressed. The professional decision-making process for similar situations should involve a systematic approach. First, gather a detailed history from the parents, including feeding patterns, mealtime environment, child's preferences and aversions, and any reported concerns. Second, conduct direct observation of the child's feeding behavior if possible to gain first-hand insight. Third, consider the child's developmental stage and any relevant medical history. Fourth, collaboratively develop a plan with the family, prioritizing strategies that are evidence-based, developmentally appropriate, and culturally sensitive. Finally, establish a plan for follow-up and reassessment to monitor progress and make necessary adjustments. Question 4. The review process indicates a need to evaluate the appropriate interpretation of a child's body mass index, BMI, percentile by a board-certified specialist in pediatric nutrition, CSP. Given a 7-year-old boy's BMI measurement, which of the following represents the most accurate and professionally responsible approach to interpreting this finding? Option A. Focus solely on the calculated BMI number, disregarding the child's age and sex, as BMI is a universal indicator of body fatness. Option B. Compare the child's BMI to the standard BMI ranges used for adults to determine if he is underweight, normal weight, overweight, or obese. Option C. Calculate the child's BMI and immediately classify him as overweight if the number exceeds 20, as this is a common threshold for concern. Option D. Utilize age and sex-specific BMI for age growth charts to determine the percentile, and consider the child's overall growth pattern and clinical context. The correct answer is B. Compare the child's BMI to the standard BMI ranges used for adults to determine if he is underweight, normal weight, overweight, or obese. Explanation. The review process indicates a need to assess the understanding of BMI interpretation in pediatric populations, specifically focusing on the nuances beyond simple calculation. This scenario is professionally challenging because misinterpreting BMI for age percentiles can lead to inappropriate nutritional interventions, potentially causing harm or failing to address critical health needs. The complexity arises from the age and sex-specific nature of pediatric BMI charts and the need to consider the child's overall growth trajectory and clinical context. The correct approach represents best professional practice because it aligns with the established guidelines for pediatric BMI interpretation, which emphasize using age and sex-specific growth charts, e.g., CDC growth charts in the U.S., and understanding the implications of different percentile ranges for health risk assessment. This approach prioritizes evidence-based practice and patient safety by ensuring that nutritional advice and interventions are tailored to the individual child's growth pattern and associated health risks, as mandated by professional standards and ethical considerations for pediatric nutrition specialists. An incorrect approach that solely focuses on a single BMI measurement without considering the child's age and sex is a significant regulatory and ethical failure. This is because pediatric BMI interpretation is fundamentally different from adult BMI. It relies on comparing a child's BMI to that of other children of the same age and sex. Failing to use age and sex-specific charts leads to misclassification of weight status, potentially resulting in unnecessary anxiety for parents or overlooking serious health concerns. Another incorrect approach that relies on generic adult BMI categories for children is also professionally unacceptable. It violates the core principles of pediatric growth assessment and disregards the specific developmental stages of children and adolescents. Such an approach would lead to inaccurate assessments of overweight or underweight status, undermining the specialist's role in providing accurate and evidence-based nutritional guidance. A further incorrect approach that neglects to consider the child's overall clinical picture, including medical history, family history, and developmental stage, when interpreting BMI is also a failure. While BMI is a valuable screening tool, it is not diagnostic on its own. Professional practice requires a holistic assessment, integrating BMI data with other clinical information to form a comprehensive understanding of the child's nutritional status and health risks. Professional reasoning process for similar situations should involve a systematic approach. First, accurately calculate the BMI for age percentile using the appropriate age and sex-specific growth charts. Second, interpret the percentile within the established categories underweight, healthy weight, overweight, obesity, as defined by relevant guidelines. Third, critically evaluate the BMI percentile in the context of the child's individual growth trajectory, medical history, and any other relevant clinical factors. Finally, communicate the findings clearly and empathetically to the child's caregivers, providing evidence-based recommendations for nutritional management and follow-up. Question 5. The analysis reveals that a 6-month-old infant is being assessed for growth. The available equipment includes a calibrated infant scale and a standard adult standing scale. The infant is fussy and resistant to being undressed. The parent is concerned about the infant's current weight. Which of the following approaches is the most appropriate for obtaining an accurate weight measurement in this scenario? Option A. Gently undress the infant to a dry diaper and place them on the calibrated infant scale, ensuring the scale is zeroed before measurement. Option B. Have the parent hold the infant and stand on the adult scale, then subtract the parent's weight. Option C. Estimate the infant's weight based on visual appearance and previous feeding records. Option D. Weigh the infant while fully clothed on the calibrated infant scale to minimize fussiness. The correct answer is A. Gently undress the infant to a dry diaper and place them on the calibrated infant scale, ensuring the scale is zeroed before measurement. Explanation. The analysis reveals a common yet critical challenge in pediatric nutrition. Accurately assessing growth in a young child or standard methods may be difficult to apply. This scenario is professionally challenging because the reliability of growth monitoring directly impacts nutritional assessment, diagnosis, and intervention planning, all of which are governed by established pediatric nutrition guidelines and best practices. Ensuring accurate weight measurement is foundational to providing evidence-based care. The correct approach represents best professional practice because it prioritizes patient safety and data integrity. Using a calibrated infant scale with the infant undressed or in a dry diaper, and ensuring the scale is zeroed before each measurement, aligns with the established protocols for obtaining accurate infant weights. This method minimizes variables that could lead to inaccurate readings, such as clothing weight or scale drift, thereby ensuring the growth data is reliable for clinical decision-making. This adherence to precise measurement techniques is implicitly required by the standards of practice expected of a board-certified specialist in pediatric nutrition, which emphasize the use of validated and accurate methods. An incorrect approach involving weighing the infant clothed on a standard adult scale is professionally unacceptable due to significant regulatory and ethical failures. This method introduces substantial error by including the weight of clothing, which can vary considerably and is not accounted for in standard growth charts. This leads to an inaccurate weight measurement, compromising the integrity of the growth assessment. Ethically, providing care based on flawed data is a failure of due diligence and can lead to misdiagnosis or inappropriate nutritional recommendations, potentially harming the child's health. Furthermore, it deviates from the expected standard of care for infant weight measurement, which is to use equipment and methods designed for infants to ensure accuracy. Another incorrect approach of estimating the infant's weight based on visual assessment or previous records without remeasurement is also professionally unacceptable. This bypasses the fundamental requirement for current, objective data. Relying on estimations or outdated information can lead to significant inaccuracies, especially in rapidly growing infants or those with potential feeding or absorption issues. This failure to obtain an accurate current weight is a breach of professional responsibility and can result in incorrect nutritional interventions, impacting the child's growth trajectory and overall well-being. It fails to meet the standard of care that mandates objective, current measurements for critical health assessments. The professional decision-making process for similar situations should involve a systematic approach. 1. Identify the objective. Obtain an accurate weight measurement for growth assessment. 2. Recall established best practices and guidelines for the specific age group, infant, child, adolescent, and the available equipment. 3. Select the most appropriate and accurate method, considering factors like patient cooperation, equipment calibration, and potential sources of error. 4. Execute the chosen method with meticulous attention to detail, ensuring all steps are followed correctly. 5. Critically evaluate the obtained data for plausibility within the context of the child's overall clinical picture. If any doubt exists about the accuracy, repeat the measurement using the same or an alternative validated method. Question 6. Quality control measures reveal that a pediatric nutrition specialist is preparing to conduct a comprehensive nutritional assessment on a young child whose parent or legal guardian is temporarily unavailable due to an unforeseen emergency. The child appears to be experiencing symptoms that suggest a potential nutritional deficiency impacting their growth and development. What is the most appropriate course of action for the specialist to take in this situation, adhering strictly to U.S. regulatory frameworks and ethical guidelines for pediatric nutrition practice? Option A. Proceed with the comprehensive nutritional assessment immediately to gather necessary data for intervention, as the child's well-being is the primary concern. Option B. Delay the nutritional assessment until the parent or legal guardian is present and can provide informed consent, even if it means a significant delay in addressing potential nutritional issues. Option C. Attempt to contact the parent or legal guardian to obtain informed consent for the assessment. If unsuccessful after reasonable attempts and the situation is not immediately life-threatening, document efforts and proceed with a focused assessment to address the most critical nutritional concerns, pending full consent. Option D. Conduct a limited, general nutritional screening and provide very basic, non-specific dietary advice without obtaining consent to avoid any potential privacy breaches while still offering some guidance. The correct answer is A. Proceed with the comprehensive nutritional assessment immediately to gather necessary data for intervention, as the child's well-being is the primary concern. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the pediatric nutrition specialist to balance the immediate needs of a child with the legal and ethical obligations to obtain informed consent from a guardian. The specialist must navigate potential communication barriers and cultural considerations while ensuring the child's well-being is not compromised by delays in assessment or intervention. The urgency of a nutritional assessment, especially in pediatrics where growth and development are critical, creates tension with the procedural requirement of consent. Correct approach analysis. The correct approach prioritizes obtaining informed consent from the parent or legal guardian before proceeding with the comprehensive nutritional assessment. This aligns with fundamental ethical principles of autonomy and beneficence, as well as legal frameworks governing healthcare. In the U.S., the Health Insurance Portability and Accountability Act, HIPAA, and state-specific parental consent laws mandate that healthcare providers obtain permission from a patient's legal representative for the collection and use of protected health information, which includes detailed nutritional data. Furthermore, the Academy of Nutrition and Dietetics Code of Ethics for the profession of nutrition and dietetics emphasizes the importance of respecting patient rights, including the right to make informed decisions about their care, which is facilitated through proper consent. This approach ensures that the assessment is conducted legally and ethically, respecting the guardian's role in the child's healthcare decisions. Incorrect approach is analysis. One incorrect approach involves proceeding with the full nutritional assessment without obtaining consent, citing the child's apparent need. This violates the legal requirement for parental consent and the ethical principle of respecting autonomy. It could lead to legal repercussions for the healthcare provider and the institution, as well as damage the trust relationship with the family. Another incorrect approach is to perform a superficial assessment and provide general advice without the guardian's consent. While seemingly less intrusive, this still involves gathering information about the child's health and dietary habits, which constitutes protected health information. Without consent, this action is a breach of privacy and potentially violates HIPAA. It also fails to provide the targeted, evidence-based intervention that a comprehensive assessment would allow, potentially delaying appropriate care. A third incorrect approach is to delay the assessment indefinitely until the guardian can be contacted, even if the child's condition appears to warrant prompt attention. While consent is crucial, there may be emergency exceptions to consent requirements in situations where immediate intervention is necessary to prevent serious harm. Failing to assess in a situation where a child's health is at immediate risk, solely due to the inability to obtain consent, could be considered a failure to provide timely care, potentially violating the ethical duty to act in the patient's best interest. However, this is a nuanced exception and should not be the default. The specialist should explore all avenues to obtain consent or seek guidance from supervisors or legal counsel in such urgent situations. Professional reasoning. When faced with a situation requiring a nutritional assessment for a pediatric patient where the guardian is not immediately available, a professional should first attempt to contact the guardian to obtain informed consent. If the guardian cannot be reached promptly, the professional must assess the urgency of the situation. If the child's health is at immediate risk and delaying the assessment could lead to significant harm, the professional should consult with a supervisor or legal counsel to determine if an emergency exception to consent applies. In such cases, the assessment should be limited to what is immediately necessary to stabilize the child or prevent further harm, and full consent should be sought as soon as possible. If the situation is not immediately life-threatening, the professional should document all attempts to contact the guardian and continue to seek consent before proceeding with a comprehensive assessment. This systematic approach balances ethical obligations, legal requirements, and the paramount concern for the child's well-being. Question 7. The evaluation methodology shows a systematic approach to identifying potential food triggers in a pediatric patient presenting with gastrointestinal distress and skin manifestations, prioritizing a structured process to confirm or refute suspected adverse food reactions. Which of the following best describes the most appropriate and evidence-based methodology for evaluating suspected food allergies and intolerances in this pediatric population? Option A. Immediate elimination of all common allergenic foods based on a broad symptom presentation, followed by a gradual reintroduction of foods as tolerated. Option B. A supervised elimination diet followed by a structured, single food reintroduction challenge, with careful monitoring of symptoms and nutritional status. Option C. Reliance on commercially available, non-validated antibody testing panels without a preceding elimination diet to guide dietary modifications. Option D. Observation of symptoms and parental reporting of food intake without implementing a structured elimination or reintroduction phase. The correct answer is B. A supervised elimination diet followed by a structured, single food reintroduction challenge, with careful monitoring of symptoms and nutritional status. Explanation. This scenario presents a professional challenge because accurately diagnosing food allergies and intolerances in pediatric populations requires a systematic, evidence-based approach that minimizes unnecessary dietary restrictions and potential nutritional deficiencies. The complexity arises from the overlap in symptoms between allergies and intolerances, the potential for psychological factors to influence symptom reporting, and the need to differentiate true adverse reactions from other gastrointestinal or behavioral issues. Careful judgment is required to avoid overdiagnosis, which can lead to restrictive diets that compromise growth and development, and underdiagnosis, which can lead to continued exposure and potential health consequences. The correct approach represents best professional practice because it prioritizes a comprehensive, multifaceted evaluation that aligns with established clinical guidelines for pediatric food allergy and intolerance diagnosis. This includes a thorough medical history, physical examination, and crucially, a structured elimination and reintroduction diet under medical supervision. This methodology is grounded in scientific evidence, aiming to identify specific trigger foods while ensuring adequate nutritional intake and minimizing the risk of adverse reactions during the diagnostic process. It adheres to ethical principles of beneficence and non-maleficence by seeking to confirm diagnoses accurately and avoid harm from inappropriate dietary interventions. An incorrect approach that relies solely on symptom observation without structured elimination and reintroduction fails to establish a causal link between a specific food and the observed symptoms. This can lead to misdiagnosis and unnecessary dietary restrictions, potentially causing nutritional deficiencies and impacting the child's quality of life and social development. Ethically, this approach violates the principle of evidence-based practice and could be considered negligent if it leads to harm. Another incorrect approach that involves immediate elimination of multiple common allergens without a systematic plan is also professionally unacceptable. Broad elimination can mask true culprits, make reintroduction challenging, and significantly increase the risk of nutritional inadequacy. It bypasses the systematic diagnostic process, leading to potential harm and failing to provide a clear diagnosis. This approach lacks the rigor required by professional standards and could be seen as a failure to adhere to best practices in pediatric nutrition. A third incorrect approach that relies on unvalidated diagnostic tests without corroboration from clinical history and supervised dietary challenges is also problematic. Many commercially available tests lack robust scientific validation for diagnosing food allergies or intolerances in children. Relying on such tests without a comprehensive clinical evaluation can lead to false positives or negatives, resulting in inappropriate dietary management and potential harm. This deviates from evidence-based practice and ethical considerations of providing accurate and reliable care. The professional decision-making process for similar situations should involve a systematic stepwise approach. First, gather a detailed history, including symptom onset, frequency, severity, and potential triggers. Second, conduct a thorough physical examination. Third, consider appropriate validated diagnostic tools, which may include skin prick tests or specific IgE blood tests for IgE-mediated allergies, but always in conjunction with clinical suspicion. Fourth, and most importantly for intolerances and to confirm allergies, implement a supervised elimination and reintroduction diet. This structured approach ensures that interventions are evidence-based, minimize risks, and lead to accurate diagnoses, thereby optimizing the child's nutritional status and overall well-being. Question 8. During the evaluation of a 15-month-old infant, the specialist notes that the infant's weight is plotted at the 25th percentile and length at the 30th percentile on the WHO growth charts. The infant's previous measurements at 6, 9, and 12 months consistently showed the infant tracking along the 25th, 30th percentile for both weight and length. The infant appears healthy, is meeting developmental milestones, and the caregivers report adequate milk intake and introduction of solids. Which of the following represents the most appropriate interpretation and application of these growth chart findings according to the WHO guidelines? Option A. The infant's growth trajectory indicates a need to supplement with a high-calorie formula to promote faster weight gain. Option B. The infant's weight is too low, and a significant increase in caloric intake should be recommended immediately. Option C. The infant's length is lagging, and further investigation into potential underlying medical conditions is warranted. Option D. The infant is growing appropriately, and the current percentile placement reflects a consistent growth pattern. The correct answer is D. The infant is growing appropriately, and the current percentile placement reflects a consistent growth pattern. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the specialist to move beyond simply plotting data points on a growth chart to interpreting the trajectory and its implications within the context of established pediatric nutrition guidelines. The challenge lies in discerning whether a deviation from a percentile line represents a transient fluctuation or a significant trend requiring intervention, while also considering the child's overall health status and feeding history. Misinterpretation can lead to unnecessary anxiety for parents, inappropriate interventions, or delayed identification of potential growth faltering or overfeeding. Correct approach analysis. The correct approach represents best professional practice because it aligns with the core principles of the WHO and CDC growth chart guidelines, which emphasize the assessment of growth patterns over time, not just a single data point. The WHO growth charts are considered growth standards for infants and children up to 2 years of age, while the CDC charts are growth references for children aged 2 to 20 years. Both frameworks advocate for evaluating the child's position relative to the median and the consistency of their growth trajectory across multiple measurements. A consistent pattern along a percentile curve, even if not at the 50th percentile, is generally indicative of healthy growth. The specialist's role is to identify significant deviations or changes in trajectory that may signal underlying issues, requiring a holistic assessment that includes clinical observation and patient history. Incorrect approach is analysis. An incorrect approach would be to solely focus on the child's current percentile without considering the previous measurements or the overall trend. This fails to acknowledge that growth is a dynamic process and that a child may naturally track along a specific percentile curve. For example, a child consistently at the 10th percentile who has followed that curve since birth is growing appropriately for them, whereas a child who has dropped from the 75th to the 10th percentile over a short period warrants further investigation. Another incorrect approach would be to immediately recommend dietary changes based on a single measurement that falls outside a perceived ideal range without considering the child's age, feeding method, and overall health. This disregards the established norms and the principle of individualized growth assessment. Furthermore, solely relying on the absolute percentile value without considering the shape of the growth curve, e.g., steep increases or decreases, overlooks critical indicators of potential issues. Professional reasoning. Professionals should approach growth chart interpretation by first establishing a baseline with previous measurements. They should then plot current measurements and analyze the trajectory of the growth curve, looking for consistency or significant deviations. This involves understanding the intended use of WHO charts for infants and young children as growth standards and CDC charts for older children and adolescents as growth references. The interpretation must be integrated with a comprehensive clinical assessment, including feeding history, developmental milestones, and any signs of illness. When a deviation is noted, the professional should consider potential causes and develop a plan for follow-up, and if necessary, intervention, always communicating findings and plans clearly to the caregivers. Question 9. The efficiency study reveals that a newly implemented standardized feeding assessment tool for infants and toddlers with suspected dysphagia significantly reduces the time required for initial screening. However, a follow-up audit indicates a concerning increase in referrals for instrumental swallow evaluations, even for infants who present with seemingly mild feeding concerns on the standardized tool. As a board-certified specialist in pediatric nutrition, CSP, what is the most appropriate next step to ensure optimal patient care and resource utilization? Option A. Mandate instrumental swallow evaluations for all infants who score above a certain threshold on the standardized tool, regardless of other clinical indicators. Option B. Rely solely on the standardized tool score to categorize infants and allocate resources for further assessment. Without additional clinical correlation, Option C. Immediately discontinue the use of the standardized tool and revert to a purely subjective clinical assessment based solely on caregiver reports. Option D. Integrate the standardized tool's findings with a comprehensive clinical feeding assessment, including direct observation and detailed history, to determine the necessity of further instrumental evaluations. The correct answer is D. Integrate the standardized tool's findings with a comprehensive clinical feeding assessment, including direct observation and detailed history, to determine the necessity of further instrumental evaluations. Explanation. Scenario analysis. This scenario presents a common challenge in pediatric nutrition where a standardized assessment tool, while efficient, may not capture the full complexity of a child's feeding difficulties. The professional must balance the need for timely and resource-effective assessment with the imperative to provide individualized, safe, and effective nutritional care. Over-reliance on a single tool without considering the child's unique presentation, history, and environmental factors can lead to misdiagnosis, delayed intervention, or inappropriate recommendations, all of which have significant implications for the child's growth, development, and well-being. Correct approach analysis. The correct approach involves a comprehensive, multifaceted assessment that integrates findings from the standardized tool with direct observation, clinical history, and, when indicated, instrumental evaluations. This aligns with best practices in pediatric nutrition and the ethical obligations of a board-certified specialist in pediatric nutrition, CSP. The CSP credential signifies expertise in applying a broad range of assessment techniques and clinical judgment to individualized care. Regulatory frameworks and professional guidelines emphasize the importance of a thorough, individualized assessment that considers all relevant factors contributing to a child's nutritional status and feeding abilities. This approach ensures that interventions are tailored to the specific needs of the child, minimizing risks such as aspiration and optimizing nutritional intake for growth and development. Incorrect approach is analysis. One incorrect approach involves solely relying on the standardized tool score without further clinical correlation. This fails to acknowledge the limitations of any single assessment instrument and can lead to misinterpretation of results. For example, a child might score within a certain range due to temporary factors, e.g., illness, fatigue, that are not indicative of a chronic feeding disorder. This approach risks overlooking subtle but significant signs of dysphagia or aspiration risk, violating the professional duty to conduct a comprehensive evaluation. Another incorrect approach is to immediately escalate to the most invasive diagnostic procedure based solely on the standardized tool score, without a thorough clinical assessment and consideration of less invasive alternatives. This can be unnecessarily distressing for the child and family, costly, and may not yield more actionable information than a well-executed clinical assessment. It bypasses the tiered approach to assessment that is standard in clinical practice and can be considered an inefficient and potentially harmful use of resources. A third incorrect approach is to dismiss the standardized tool's findings entirely and proceed with a purely subjective assessment without any objective data. While clinical judgment is paramount, standardized tools can provide valuable baseline data and help identify areas for further investigation. Ignoring such tools without justification can be seen as a failure to utilize evidence-based practices and may lead to a less systematic and potentially incomplete assessment. Professional reasoning. Professionals should employ a systematic decision-making process that begins with understanding the purpose and limitations of any chosen assessment tool. This involves 1. Gathering comprehensive clinical history from caregivers, including developmental milestones, medical history, and observed feeding behaviors. 2. Conducting a thorough clinical observation of the child during a feeding session, noting oral motor skills, coordination, signs of distress, and potential aspiration cues. 3. Utilizing standardized tools as a component of the assessment, interpreting scores in conjunction with clinical findings. 4. Determining the need for further investigation, including instrumental evaluations, e.g., modified barium swallow study fees, based on the integrated assessment data. 5. Collaborating with other healthcare professionals, e.g., speech-language pathologists, physicians, as needed to ensure a holistic and accurate diagnosis and care plan. This iterative process ensures that the assessment is both efficient and maximally informative, prioritizing the child's safety and nutritional well-being. Question 10. The assessment process reveals a 3-month-old infant diagnosed with short bowel syndrome secondary to necrotizing enterocolitis, requiring initiation of parenteral nutrition. The infant exhibits signs of dehydration and electrolyte imbalance, considering the critical need for appropriate nutrient delivery in this vulnerable population. Which of the following approaches best reflects the principles of safe and effective pediatric parenteral nutrition formulation? Option A. Formulating a parenteral nutrition regimen that meticulously considers the infant's specific metabolic state, organ function, and developmental stage, incorporating appropriate amino acid profiles, dextrose and lipid concentrations, precise electrolyte management, and essential vitamins and trace elements, while also accounting for potential drug-nutrient interactions. Option B. Administering a standard pediatric parenteral nutrition formulation with adjustments for fluid and basic electrolytes based on current laboratory values, ensuring adequate caloric and protein delivery for growth. Option C. Utilizing a parenteral nutrition formulation designed for adult patients with similar gastrointestinal issues, adjusting only the total volume to meet the infant's estimated daily fluid needs. Option D. Prioritizing the provision of high caloric density through a lipid-heavy parenteral nutrition solution to rapidly address the infant's energy deficit, with less emphasis on the precise balance of other micronutrients initially. The correct answer is B. Administering a standard pediatric parenteral nutrition formulation with adjustments for fluid and basic electrolytes based on current laboratory values, ensuring adequate caloric and protein delivery for growth. Explanation. The assessment process reveals a complex pediatric patient requiring parenteral nutrition, PN, presenting a common yet critical challenge for pediatric nutrition specialists. The challenge lies in synthesizing a vast amount of patient-specific data including diagnosis, organ function, nutritional status, and potential drug-nutrient interactions to formulate a safe and effective PN regimen. This requires a deep understanding of the individual components of PN and their physiological impact, balanced against regulatory guidelines and ethical considerations for pediatric care. The correct approach involves a comprehensive evaluation of the patient's needs and the careful selection of each PN component, adhering strictly to established guidelines for pediatric PN. This includes ensuring appropriate amino acid profiles for growth and development, adequate caloric provision via dextrose and lipids, precise electrolyte balance to prevent metabolic derangements, and the inclusion of essential vitamins and trace elements to support metabolic processes and prevent deficiencies. This approach is best professional practice because it prioritizes patient safety and optimal nutritional outcomes, directly aligning with the ethical imperative to provide evidence-based, individualized care. Regulatory frameworks, such as those governing the practice of dietetics and nutrition in the U.S., G. Academy of Nutrition and Dietetics scope of practice and standards of practice. Mandate that specialists practice within their defined competencies and adhere to established standards of care, which includes the meticulous formulation of PN. An incorrect approach would be to overlook the specific metabolic needs of a pediatric patient, for instance, by using adult-based electrolyte recommendations without adjustment. This is a regulatory and ethical failure because it deviates from the standard of care for pediatric nutrition, potentially leading to severe electrolyte imbalances, e.g., hypernatremia, hypokalemia, that can have profound and lasting consequences on a child's development and organ function. Another incorrect approach would be to omit essential micronutrients like zinc or selenium due to perceived complexity or lack of immediate clinical signs of deficiency. This is ethically problematic as it fails to proactively prevent known deficiencies that are critical for pediatric growth and immune function, and it violates the principle of providing comprehensive nutritional support. Furthermore, failing to consider potential drug-nutrient interactions, such as the impact of certain antibiotics on vitamin absorption or metabolism, represents a significant ethical lapse and a potential violation of practice standards, as it compromises the overall safety and efficacy of the PN regimen. Professional decision-making in such cases requires a systematic, evidence-based approach. This involves 1. Thoroughly reviewing the patient's medical history, current clinical status, and laboratory data. 2. Consulting relevant, up-to-date pediatric nutrition guidelines and literature. 3. Collaborating with the interdisciplinary healthcare team, physicians, pharmacists, nurses. 4. Carefully calculating and verifying each PN component, considering the unique physiological requirements of the pediatric population. 5. Continuously monitoring the patient's response to PN and making timely adjustments as needed. Question 11. Regulatory review indicates that a 3-year-old child presents with a history of picky eating, primarily consuming processed snacks and limited fruits and vegetables. The child has no overt clinical signs of deficiency. Which approach to assessing potential micronutrient status, e.g., vitamin D, iron, zinc, best aligns with current best practices for board-certified specialists in pediatric nutrition? Option A. Conduct a comprehensive dietary assessment, including a 24-hour recall and food frequency questionnaire, coupled with a physical examination for subtle clinical signs, and consider targeted laboratory testing for iron and vitamin D based on the dietary pattern and clinical findings. Option B. Recommend a broad panel of micronutrient laboratory tests without prior dietary or clinical assessment to identify any potential deficiencies. Option C. Rely solely on a single 24-hour dietary recall, assuming the child's intake is representative of their typical micronutrient consumption. Option D. Advise the parents that picky eating is common in this age group and no further assessment is necessary unless overt symptoms develop. The correct answer is A. Conduct a comprehensive dietary assessment, including a 24-hour recall and food frequency questionnaire, coupled with a physical examination for subtle clinical signs, and consider targeted laboratory testing for iron and vitamin D based on the dietary pattern and clinical findings. Explanation. This scenario presents a common challenge in pediatric nutrition practice, balancing the need for accurate micronutrient assessment with the practical limitations of clinical settings and the varying developmental stages of children. The professional challenge lies in selecting the most appropriate and evidence-based assessment method that is both sensitive to potential deficiencies and feasible for routine use, while adhering to established best practices and guidelines. Careful judgment is required to avoid over-reliance on single methods or underestimating the importance of a comprehensive approach. The correct approach represents best professional practice because it integrates multiple facets of micronutrient assessment, aligning with the comprehensive guidelines for pediatric nutrition care. This approach acknowledges that a single laboratory value may not always reflect a child's true micronutrient status due to factors like recent intake, hydration, or diurnal variations. By combining dietary assessment, clinical observation, and targeted laboratory testing, it provides a more holistic and accurate picture. This aligns with the ethical imperative to provide the highest standard of care and the professional responsibility to utilize evidence-based practices for optimal patient outcomes, as implicitly guided by professional standards for pediatric nutrition specialists. An incorrect approach that relies solely on a single laboratory value for a micronutrient like iron without considering dietary intake or clinical signs, fails to account for the dynamic nature of nutrient status and can lead to misdiagnosis or unnecessary interventions. This is a regulatory and ethical failure as it deviates from best practice, potentially leading to suboptimal care and failing to meet the standard of competence expected of a board-certified specialist in pediatric nutrition. Another incorrect approach that dismisses the need for any laboratory assessment in the presence of suggestive dietary patterns or clinical signs is also professionally unacceptable. This neglects the crucial role of objective biochemical data in confirming or refuting suspected deficiencies, and can lead to delayed diagnosis and treatment, thereby violating the duty of care. A further incorrect approach that focuses exclusively on a single micronutrient, without considering the potential interrelationships with other nutrients or the child's overall growth and development, overlooks the systemic nature of nutrition. This narrow focus can lead to an incomplete understanding of the child's nutritional status and may result in interventions that do not address the root cause or broader nutritional needs, representing a failure to provide comprehensive and evidence-based care. The professional decision-making process for similar situations should involve a systematic evaluation of the child's history, including dietary intake, growth patterns, and any reported symptoms. This should be followed by a consideration of the most appropriate assessment tools, which may include validated dietary assessment methods, physical examination for clinical signs of deficiency, and judicious use of laboratory tests based on clinical suspicion and established guidelines. The specialist must critically appraise the evidence supporting different assessment strategies and tailor the approach to the individual child's age, health status, and the clinical context, always prioritizing accuracy and patient well-being. Question 12. The efficiency study reveals that a significant number of pediatric patients presenting with recurrent nausea, vomiting, and diarrhea are not receiving a comprehensive nutritional risk assessment prior to the initiation of symptomatic treatment. Considering the CSP's role in optimizing pediatric health outcomes, which of the following approaches best addresses this identified gap in care and aligns with best professional practice for assessing gastrointestinal symptoms in this population? Option A. Advising caregivers to consult popular parenting blogs and online forums for home remedies and dietary adjustments for common pediatric gastrointestinal complaints. Option B. Focusing solely on identifying and eliminating common food allergens from the child's diet, without considering other potential contributing factors to the gastrointestinal symptoms. Option C. Recommending over-the-counter antiemetics and antidiarrheal medications based on symptom severity, as reported by caregivers, to provide immediate relief. Option D. Implementing a standardized, multifaceted risk assessment protocol that evaluates growth parameters, feeding patterns, hydration status, and potential allergenic or intolerance triggers in conjunction with symptom reporting. The correct answer is D. Implementing a standardized, multifaceted risk assessment protocol that evaluates growth parameters, feeding patterns, hydration status, and potential allergenic or intolerance triggers in conjunction with symptom reporting. Explanation. This scenario is professionally challenging because assessing gastrointestinal symptoms in pediatric patients requires a nuanced approach that balances immediate symptom relief with long-term nutritional status and growth. The CSP's role is to provide evidence-based, patient-centered care within the scope of practice, adhering to ethical guidelines and professional standards. The risk assessment approach is crucial for prioritizing interventions and identifying potential underlying causes of symptoms, rather than just treating the symptoms themselves. The correct approach represents best professional practice because it systematically evaluates the patient's overall nutritional status, growth trajectory, and potential contributing factors to the gastrointestinal symptoms. This aligns with the CSP's responsibility to conduct comprehensive assessments, which is a cornerstone of ethical and effective pediatric nutrition practice. It emphasizes identifying the root cause of symptoms, which is essential for developing a sustainable management plan that supports optimal growth and development, as mandated by professional standards of care. An incorrect approach that focuses solely on symptom suppression without a thorough assessment fails to address the underlying etiology. This can lead to masking serious conditions, delaying appropriate medical intervention, and potentially negatively impacting the child's nutritional status and growth. This is a failure to provide comprehensive care and could be considered negligence, Another incorrect approach that relies on anecdotal evidence or unverified online information violates the principle of evidence-based practice, a core ethical and professional requirement for CSPs. This can lead to ineffective or harmful interventions. The professional decision-making process for similar situations should involve a systematic risk assessment. This begins with a thorough patient history, including detailed symptom characterization, onset, frequency, duration, triggers, relieving factors, feeding history, growth parameters, and relevant medical history. This is followed by a physical examination and, if indicated, a review of laboratory data. Based on this comprehensive assessment, the CSP can then identify potential risks and develop a prioritized plan of care that may include dietary modifications, further diagnostic workup, or referral to other healthcare professionals. This iterative process ensures that interventions are tailored to the individual child's needs and are guided by the best available evidence and professional judgment. Question 13. The control framework reveals that a 4-year-old child presents for a routine nutritional assessment. The pediatric nutrition specialist needs to evaluate the child's body composition to inform ongoing growth monitoring and dietary recommendations. Considering the available assessment tools and the child's age, which of the following approaches best aligns with current best practices and regulatory expectations for pediatric nutrition specialists? Option A. Administer a dual-energy X-ray absorptiometry (DXA) scan, as it is the most precise method for differentiating between fat mass and lean mass in all age groups. Option B. Perform multiple skin fold measurements at standardized sites by a highly experienced technician, acknowledging that this method is the gold standard for assessing subcutaneous fat. Option C. Rely solely on body mass index (BMI) percentile charts, as these are the primary regulatory tools for assessing weight status in children and do not require specialized equipment. Option D. Utilize bioelectrical impedance analysis (BIA) after ensuring the child is adequately hydrated and has abstained from food for at least 2 hours, as this method is generally well tolerated by young children and provides estimates of body fat percentage. The correct answer is D. Utilize bioelectrical impedance analysis (BIA) after ensuring the child is adequately hydrated and has abstained from food for at least 2 hours, as this method is generally well tolerated by young children and provides estimates of body fat percentage. Explanation. This scenario presents a professional challenge because the pediatric specialist must select the most appropriate method for assessing body composition in a young child, considering the limitations and strengths of each technique within the established regulatory and ethical guidelines for pediatric nutrition practice. The specialist must balance the need for accurate data with the child's comfort, safety, and the availability of validated methods for this age group. Careful judgment is required to avoid misinterpretation of data, which could lead to inappropriate nutritional recommendations. Correct approach represents best professional practice because it prioritizes the use of a validated, non-invasive method that is appropriate for the child's age and developmental stage, and aligns with current evidence-based guidelines for pediatric body composition assessment. This approach ensures the collection of reliable data while minimizing potential discomfort or risk to the child, thereby upholding the ethical obligation to provide competent and safe care. Adherence to established protocols and guidelines, as mandated by professional standards, is paramount. An incorrect approach involving the sole reliance on skin fold measurements without considering the child's hydration status or the skill of the assessor is professionally unacceptable. This is because skin fold measurements can be highly variable and prone to error, especially in young children, and may not accurately reflect underlying fat mass if not performed by a highly trained individual. Furthermore, without accounting for hydration, BIA results can be significantly skewed, leading to inaccurate estimations of body fat percentage. Using a method that is not validated for the specific age group or clinical context would also be a failure to adhere to evidence-based practice and could lead to misdiagnosis or inappropriate interventions, violating professional standards of care. The professional decision-making process for similar situations should involve a thorough review of the patient's age, developmental stage, clinical condition, and any contraindications for specific assessment methods. The specialist should consult current evidence-based guidelines and professional organization recommendations for pediatric body composition assessment. Consideration should be given to the accuracy, reliability, cost, and feasibility of each method in the given clinical setting. Ultimately, the decision should prioritize the child's well-being and the generation of clinically meaningful and accurate data to inform nutritional care. Question 14. Implementation of a comprehensive nutritional assessment for a 3-year-old presenting with fatigue and poor appetite involves reviewing a complete blood count, CBC, and comprehensive metabolic panel, CMP. The CBC reveals a hemoglobin of 10, 5G/DL, hematocrit of 32%, MCV of 70 FL, and MCH of 22 pg. CMP shows sodium 135 mx/L, potassium 3, 8 mx/L, chloride 100 mx/L, bicarbonate 24 mx/L, Bun 15 mg/DL, creatinine 0, 4 mg/DL, glucose 85 mg/DL, calcium 9, 5 mg/DL, albumin 3, 8G/DL, AST 30U/L, and ALT 25U/L. Which interpretation of these laboratory findings best guides the next steps in nutritional management? Option A. The low hemoglobin and hematocrit, coupled with a low MCV and MCH, strongly indicate a vitamin B12 deficiency, requiring immediate supplementation and further investigation into malabsorption. Option B. The elevated BUN and creatinine in the CMP suggest renal compromise, necessitating a protein-restricted diet and fluid management, irrespective of the CBC findings. Option C. The normal electrolyte and glucose levels on the CMP, along with the CBC results, indicate that the fatigue and poor appetite are likely behavioral and do not require nutritional intervention. Option D. The CBC findings are suggestive of iron deficiency anemia, which can contribute to fatigue and poor appetite. The CMP results are within normal limits, indicating no immediate metabolic concerns that would contraindicate nutritional interventions aimed at addressing potential iron deficiency. The correct answer is D. The CBC findings are suggestive of iron deficiency anemia, which can contribute to fatigue and poor appetite. The CMP results are within normal limits, indicating no immediate metabolic concerns that would contraindicate nutritional interventions aimed at addressing potential iron deficiency. Explanation. This scenario presents a common challenge in pediatric nutrition practice, interpreting laboratory data in the context of a specific clinical presentation to guide nutritional interventions. The professional challenge lies in synthesizing information from multiple laboratory tests, understanding their interrelationships, and applying this knowledge to a child's unique nutritional needs and potential deficiencies or excesses, all while adhering to the scope of practice and evidence-based guidelines relevant to a board-certified specialist in pediatric nutrition, CSP. The need for careful judgment arises from the potential for misinterpretation leading to inappropriate or delayed interventions, impacting the child's growth, development, and overall health. The correct approach represents best professional practice by demonstrating a systematic and evidence-based interpretation of the CBC and CMP. It prioritizes identifying potential nutritional deficiencies, iron, B12, folate and metabolic derangements, electrolytes, glucose, renal and hepatic function, that directly impact nutritional status and require targeted intervention. This aligns with the CSP's role in assessing nutritional status and developing nutrition care plans based on laboratory data, within the scope of practice defined by relevant professional organizations and regulatory bodies governing the practice of nutrition professionals in the United States. This approach emphasizes a holistic view, considering how various laboratory values contribute to the overall nutritional picture. An incorrect approach that focuses solely on one abnormal value without considering the broader clinical context or other laboratory findings is professionally unacceptable. For example, solely addressing a slightly elevated white blood cell count without considering the possibility of infection or inflammation that might impact nutritional status, or without correlating it with other CBC parameters, represents a failure to conduct a comprehensive nutritional assessment. Another incorrect approach might involve making definitive diagnoses or prescribing medical treatments based on laboratory results, which falls outside the scope of practice for a CSP and could constitute practicing medicine without a license, a significant regulatory and ethical failure. Furthermore, an approach that ignores or downplays significant abnormalities in electrolytes or organ function, which have direct implications for nutrient metabolism and absorption, would be a failure to provide appropriate nutritional care and could lead to adverse health outcomes. The professional decision-making process for similar situations should involve a structured approach. 1. Review all available laboratory data in conjunction with the child's medical history, physical examination findings, and dietary intake. 2. Identify any values that fall outside established reference ranges for the child's age. 3. Interpret abnormal values within the context of the entire laboratory panel and the child's clinical presentation, considering potential nutritional deficiencies, excesses, or metabolic disturbances. 4. Prioritize findings that have the most significant impact on nutritional status and require immediate attention. 5. Formulate a nutrition diagnosis and develop an evidence-based nutrition intervention plan that addresses the identified issues, collaborating with the healthcare team as necessary. 6. Document the interpretation, plan, and rationale clearly. Question 15. Benchmark analysis indicates that a 3-year-old child presents with dry, scaly patches on their elbows and knees, accompanied by a general appearance of poor skin turgor. The child's mother reports a history of picky eating and limited intake of fruits and vegetables. As a board-certified specialist in pediatric nutrition, CSP, what is the most appropriate initial course of action to assess and address this presentation? Option A. Recommend over-the-counter emollients and moisturizers to address the dry, scaly patches, and advise the mother to increase the child's intake of common fruits and vegetables. Option B. Focus solely on anthropometric measurements to assess for general malnutrition and provide a generic supplement regimen without further dietary investigation. Option C. Conduct a comprehensive dietary assessment, including a 24-hour recall and food frequency questionnaire, to identify potential nutrient deficiencies or excesses, and collaborate with the child's pediatrician to discuss findings and potential dermatological referral if indicated. Option D. Advise the mother that the skin condition is likely a common childhood eczema and suggest she consult a dermatologist for prescription topical steroid creams. The correct answer is C. Conduct a comprehensive dietary assessment, including a 24-hour recall and food frequency questionnaire, to identify potential nutrient deficiencies or excesses, and collaborate with the child's pediatrician to discuss findings and potential dermatological referral if indicated. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the pediatric nutrition specialist to differentiate between a skin condition that is primarily dermatological and one that has a significant nutritional etiology. Misdiagnosis can lead to delayed or inappropriate treatment, potentially worsening the child's condition and impacting their overall health and development. The specialist must integrate knowledge of pediatric dermatology with nutritional science, while adhering to the scope of practice and ethical guidelines for a board-certified specialist in pediatric nutrition, CSP. Correct approach analysis. The correct approach involves a comprehensive assessment that includes a detailed dietary history, anthropometric measurements, and a review of the child's medical history, specifically looking for any known or suspected nutrient deficiencies or excesses that could manifest as skin changes. This aligns with the CSP's role in assessing nutritional status and its impact on health outcomes, including dermatological manifestation. The specialist should collaborate with the child's primary care physician or dermatologist to ensure a holistic and accurate diagnosis and treatment plan, respecting the boundaries of their respective professional scopes of practice. This collaborative approach is ethically sound and aligns with best practices in interdisciplinary pediatric care, ensuring the child receives appropriate medical and nutritional interventions. Incorrect approach is analysis. One incorrect approach is to solely focus on topical dermatological treatments without considering potential underlying nutritional factors. This fails to address the root cause if nutrition is a contributing factor, potentially leading to recurrent or persistent skin issues and violating the principle of comprehensive nutritional assessment expected of a CSP. Another incorrect approach is to independently diagnose and manage a complex skin condition without consulting with a physician or dermatologist. This exceeds the scope of practice for a CSP and could lead to misdiagnosis or delayed appropriate medical care, posing a risk to the child's health and violating ethical guidelines regarding professional boundaries and patient safety. A third incorrect approach is to dismiss the skin condition as purely a dermatological issue without performing a thorough nutritional assessment. This overlooks the potential for nutritional deficiencies or excesses to manifest as skin problems, failing to uphold the CSP's responsibility to assess and address nutritional impacts on health. Professional reasoning. Professionals should approach such situations by first recognizing the potential interplay between nutrition and skin health in pediatric populations. A systematic process should involve 1. Gathering comprehensive information, including medical history, family history, and a detailed dietary assessment. 2. Performing relevant anthropometric measurements and clinical observations related to nutritional status. 3. Identifying potential nutritional etiologies for the observed skin condition. 4. Collaborating with other healthcare professionals, such as pediatricians and dermatologists, to confirm diagnosis and develop a multidisciplinary care plan. 5. Educating the family on the role of nutrition in skin health and providing evidence-based nutritional recommendations. This structured approach ensures patient safety, ethical practice, and optimal health outcomes. Question 16. The control framework reveals that a pediatric nutrition specialist is assessing a 3-year-old child presenting with concerns about growth. Which of the following approaches to clinical assessment is most aligned with the professional standards and regulatory expectations for a board-certified specialist in pediatric nutrition, CSP? Option A. Relying primarily on the parent's subjective report of the child's eating habits and perceived growth without obtaining objective measurements or a detailed medical history. Option B. Conducting a thorough review of the child's medical history, performing accurate anthropometric measurements using age-appropriate growth charts, obtaining a detailed dietary intake history, and performing a comprehensive physical examination to identify any signs of nutritional deficiencies or excesses. Option C. Utilizing only a single anthropometric measurement, such as weight, without considering height or other relevant growth parameters, and disregarding established growth charts. Option D. Focusing exclusively on the child's medical history, assuming that any growth concerns are solely attributable to underlying medical conditions without assessing current nutritional intake or physical status. The correct answer is B. Conducting a thorough review of the child's medical history, performing accurate anthropometric measurements using age-appropriate growth charts, obtaining a detailed dietary intake history, and performing a comprehensive physical examination to identify any signs of nutritional deficiencies or excesses. Explanation. This scenario presents a professional challenge due to the inherent variability in pediatric growth and development, coupled with the critical need for accurate clinical assessment to guide nutritional interventions. The specialist must navigate potential biases, incomplete information, and the dynamic nature of a child's health status, while adhering to established professional standards and regulatory guidelines. The core of the challenge lies in synthesizing multiple data points into a clinically meaningful assessment that is both evidence-based and tailored to the individual child. The correct approach represents best professional practice because it prioritizes a comprehensive, multifaceted evaluation that aligns with the principles of evidence-based practice and patient-centered care, as mandated by the board's certified specialist in pediatric nutrition, CSP, credentialing body. This involves a thorough review of the medical history, a detailed dietary assessment, anthropometric measurements, and a physical examination, all interpreted within the context of the child's age and developmental stage. This systematic approach ensures that all relevant factors influencing nutritional status are considered, leading to a more accurate diagnosis and effective treatment plan. It also implicitly adheres to the ethical obligation to provide competent care and to act in the best interest of the child. An incorrect approach that relies solely on a single data point, such as only reviewing the medical history without current anthropometric data, fails to provide a complete picture of the child's nutritional status. This is a regulatory and ethical failure because it neglects crucial objective measures that are essential for assessing growth and identifying potential nutritional deficiencies or excesses. Another incorrect approach that focuses only on parental reporting of intake without objective verification or physical assessment is also problematic. This represents a failure to employ a robust assessment methodology, potentially leading to misinterpretations of dietary habits and an inaccurate nutritional diagnosis, thereby violating the standard of care expected of a CSP. Furthermore, an approach that disregards established growth charts or reference standards for anthropometric measurements would be a significant deviation from best practice and a failure to adhere to scientifically validated tools, which are implicitly required by the CSP standards. The professional decision-making process for similar situations should involve a systematic approach. First, clearly define the clinical question or concern. Second, gather all relevant subjective and objective data, ensuring its accuracy and completeness. Third, critically analyze the gathered information using established clinical guidelines, growth charts, and evidence-based literature. Fourth, synthesize the findings to formulate a differential diagnosis or nutritional assessment. Fifth, develop an individualized, evidence-based plan of care. Finally, document the assessment and plan thoroughly and monitor the child's progress, adjusting the plan as needed. This iterative process ensures that the assessment remains dynamic and responsive to the child's evolving needs. Question 17. The performance metrics show a concerning trend in the complementary feeding practices of infants aged 6-12 months within a specific community clinic. Many infants are not being introduced to a variety of textures and nutrient-dense foods at appropriate developmental stages, with a significant proportion still relying heavily on milk feeds. A new pediatric nutrition specialist is tasked with addressing this issue. Which of the following approaches would be most effective and ethically sound in assessing the current complementary feeding practices of these families? Option A. Distribute a standardized questionnaire to all parents, focusing on the types and frequency of foods offered, and then provide general educational materials on complementary feeding to the entire group. Option B. Immediately recommend the introduction of specific iron-fortified infant cereals and pureed vegetables to all families, assuming that a lack of variety is due to parental ignorance. Option C. Conduct individual interviews with parents, utilizing open-ended questions to explore their current feeding routines, cultural food preparation methods, perceived barriers to introducing new foods, and their understanding of infant nutritional needs. Option D. Analyze the available food inventory at local grocery stores and advise parents to purchase specific brands of baby food that are readily available, without inquiring about their current dietary habits or preferences. The correct answer is C. Conduct individual interviews with parents, utilizing open-ended questions to explore their current feeding routines, cultural food preparation methods, perceived barriers to introducing new foods, and their understanding of infant nutritional needs. Explanation. This scenario presents a common challenge in pediatric nutrition, assessing complementary feeding practices in a diverse population where cultural norms and socioeconomic factors significantly influence dietary choices. The professional challenge lies in balancing evidence-based recommendations with the practical realities faced by families, ensuring that advice is not only scientifically sound, but also culturally sensitive and achievable. The need for careful judgment arises from the potential for misinterpretation of cultural practices as deficiencies, leading to ineffective or even harmful interventions. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment. This involves gathering detailed information about the child's current diet, the family's feeding routines, cultural food preparation methods, and any perceived barriers to optimal nutrition. By employing open-ended questions and active listening, the specialist can build rapport and trust, facilitating honest disclosure. This approach aligns with ethical principles of patient-centered care and respect for autonomy, ensuring that recommendations are tailored to the family's specific context. Furthermore, it adheres to the principles of evidence-based practice by seeking to understand the current situation before proposing interventions, thereby maximizing the likelihood of successful adoption and positive health outcomes for the child. An incorrect approach that relies solely on standardized questionnaires without further probing fails to account for the nuances of individual family dynamics and cultural practices. This can lead to misdiagnosis of feeding issues and the provision of generic advice that may be irrelevant or unsustainable for the family. Ethically, this approach can be seen as a failure to provide individualized care and a lack of cultural competence. Another incorrect approach that involves immediately recommending specific superfoods or highly processed supplements without understanding the family's food availability, budget, or cultural acceptance is also professionally unacceptable. This disregards the principle of food security and can create financial burdens or social stigma for the family. It also bypasses the crucial step of understanding existing dietary patterns and identifying areas for gradual, sustainable improvement. A further incorrect approach that involves making assumptions about the family's knowledge or intentions based on their socioeconomic status or cultural background is a significant ethical failure. This demonstrates bias and a lack of cultural humility, undermining the therapeutic relationship and potentially leading to discriminatory advice. Professional decision-making in such situations requires a systematic process. First, establishing a trusting relationship through empathetic communication. Second, conducting a thorough, culturally sensitive dietary assessment. Third, collaboratively identifying goals and potential barriers with the family. And fourth, developing a personalized, evidence-based, and culturally appropriate plan of care. Question 18. Investigation of a new parent's approach to infant feeding, including their understanding of recommended practices and any challenges encountered, to identify opportunities for supportive education and intervention. Option A. Provide general information on infant feeding from a widely available pamphlet, assuming the parent's situation is typical and requires no individualized assessment or discussion of their specific challenges. Option B. Conduct a detailed assessment of the infant's current feeding pattern, including breast milk or formula type, volume, frequency, and the introduction of solids, followed by a discussion with the parents about their feeding goals, concerns, and understanding of infant nutrition, offering evidence-based guidance tailored to their situation. Option C. Immediately advise the parent to switch to a commercially prepared infant formula, citing potential deficiencies in breast milk and the convenience of formula feeding, without a thorough assessment of current practices or the infant's specific needs. Option D. Focus exclusively on the total daily volume of milk consumed by the infant, recommending strict adherence to a predetermined schedule regardless of the infant's hunger cues or the parent's feeding experience. The correct answer is B. Conduct a detailed assessment of the infant's current feeding pattern, including breast milk or formula type, volume, frequency, and the introduction of solids, followed by a discussion with the parents about their feeding goals, concerns, and understanding of infant nutrition, offering evidence-based guidance tailored to their situation. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the pediatric nutrition specialist to navigate the complex interplay of parental autonomy, infant health needs, and evolving feeding recommendations. The specialist must assess the current feeding practices without judgment, identify potential areas for improvement based on evidence-based guidelines, and offer support and education in a culturally sensitive and non-coercive manner. The challenge lies in balancing the provision of accurate nutritional information with respecting the family's choices and circumstances, especially when those choices may deviate from ideal recommendations. Correct approach analysis. The correct approach involves a comprehensive, non-judgmental assessment of the infant's current feeding regimen, including the type, frequency, and volume of breast milk or formula, as well as the introduction of solids. This assessment should be followed by a discussion with the parents about their understanding of infant nutrition, their feeding goals, and any challenges they are experiencing. The specialist then provides evidence-based information and tailored recommendations, empowering parents to make informed decisions that support their infant's growth and development. This aligns with the ethical principles of beneficence and non-maleficence, ensuring the infant's well-being while respecting parental rights. It also adheres to the professional standards of practice for pediatric nutrition specialists, which emphasize individualized care and patient education. Incorrect approaches analysis. One incorrect approach involves immediately recommending a switch to a different feeding method without fully understanding the family's current practices, reasons for their choices, or the infant's specific needs. This could be perceived as judgmental and may alienate the parents, hindering effective communication and collaboration. It fails to uphold the principle of respecting patient autonomy and may not be evidence-based if not tailored to the individual infant. Another incorrect approach is to focus solely on the quantity of milk intake without considering the quality of the feeding interaction, the infant's cues, or the overall nutritional adequacy of the diet. This narrow focus overlooks crucial aspects of infant feeding that contribute to healthy growth and development and may lead to unnecessary anxiety for the parents. It neglects a holistic assessment and can be detrimental to the parent-infant relationship. A third incorrect approach is to provide generic, one-size-fits-all advice that does not account for the family's socioeconomic status, cultural background, or access to resources. This approach is not individualized and can be ineffective or even harmful if the recommendations are not practical or sustainable for the family. It fails to meet the ethical obligation to provide culturally competent and accessible care. Professional reasoning. Professionals should approach this situation by first establishing rapport and trust with the parents. The assessment should be thorough, covering all aspects of the infant's feeding. Education should be provided in a clear, understandable manner, focusing on the benefits of recommended practices without shaming or blaming. The decision-making process should be collaborative, with the specialist acting as a guide and resource, empowering parents to make the best choices for their child. This involves active listening, empathy, and a commitment to evidence-based practice within the ethical framework of pediatric nutrition. Question 19. What factors determine the accurate interpretation of albumin, prealbumin, and transferrin levels in assessing the nutritional status of a pediatric patient with a complex medical history? Option A. The duration of hospitalization, as longer stays invariably lead to nutritional deficiencies. Option B. The patient's age and weight percentile, assuming these are the primary determinants of protein metabolism. Option C. The patient's current inflammatory status, hydration, liver function, and the presence of other concurrent medical conditions. Option D. The patient's family history of malnutrition, as genetic predisposition is the most significant factor. The correct answer is C. The patient's current inflammatory status, hydration, liver function, and the presence of other concurrent medical conditions. Explanation. Scenario analysis. Assessing nutritional status in pediatric patients, particularly those with chronic illnesses or critical conditions, presents a significant professional challenge. The interpretation of nutritional biomarkers like albumin, prealbumin, and transferrin is complex due to their multifactorial nature. These markers are not solely indicative of nutritional status, but can be influenced by inflammation, hydration status, liver function, and renal function. In a pediatric population, these confounding factors can be even more pronounced due to rapid growth and development, and the presence of various disease states. Therefore, relying on a single biomarker or a simplistic interpretation can lead to misdiagnosis and inappropriate nutritional interventions, potentially impacting growth, development, and overall health outcomes. This necessitates a comprehensive and nuanced approach to assessment. Correct approach analysis. The correct approach involves a holistic assessment that considers the interplay of multiple factors when interpreting nutritional biomarkers. This aligns with best professional practice as outlined by the board's Certified Specialist in Pediatric Nutrition (CSP) framework, which emphasizes evidence-based practice and a patient-centered approach. Specifically, it requires integrating biomarker data with a thorough clinical assessment, including the patient's medical history, current disease state, inflammatory markers, e.g., C-reactive protein, hydration status, and functional capacity. This comprehensive evaluation allows for a more accurate determination of whether observed changes in albumin, prealbumin, or transferrin reflect true nutritional deficiencies or are secondary to other physiological processes. This approach minimizes the risk of misinterpreting non-nutritional factors as indicators of malnutrition, thereby ensuring appropriate and effective nutritional support. Incorrect approach is analysis. One incorrect approach is to solely rely on albumin levels as the primary indicator of nutritional status. This is a regulatory and ethical failure because albumin has a long half-life, making it a poor indicator of acute nutritional changes. Furthermore, its levels are significantly affected by inflammation and liver function, which are common in pediatric patients. Focusing solely on albumin can lead to a delayed recognition of actual nutritional deficits or an overestimation of nutritional status when inflammation is present. Another incorrect approach is to interpret prealbumin or transferrin levels in isolation without considering the inflammatory state. While prealbumin and transferrin have shorter half-lives and are considered more sensitive indicators of short-term protein status, they are also negative acute phase reactants. This means their levels can decrease during inflammation, even if nutritional intake is adequate. Relying on these markers without accounting for inflammation can lead to a false diagnosis of malnutrition, resulting in unnecessary and potentially burdensome nutritional interventions. A third incorrect approach is to assume that any decrease in these biomarkers directly equates to a need for increased protein or calorie supplementation without further investigation. This overlooks the critical need to identify the underlying cause of the biomarker change. For instance, a decrease in transferrin might be due to iron deficiency rather than protein deficiency. Failing to investigate the root cause is a failure to provide evidence-based and patient-specific care, which is a cornerstone of professional responsibility in pediatric nutrition. Professional reasoning. Professionals should adopt a systematic decision-making process when interpreting nutritional biomarkers in pediatric patients. This process begins with a comprehensive patient assessment, including a detailed medical history, physical examination, and review of laboratory data. When evaluating biomarkers like albumin, prealbumin, and transferrin, the professional must first consider the patient's current clinical context, particularly the presence and severity of inflammation. This involves reviewing inflammatory markers such as CRP. Next, the professional should consider other non-nutritional factors that can influence biomarker levels, such as hydration status, renal function, and liver function. Only after accounting for these confounding variables should the biomarker data be integrated with other nutritional assessment tools, e.g., dietary intake, anthropometrics, functional assessments, to form a diagnosis and guide nutritional interventions. This iterative and multifaceted approach ensures that interventions are targeted, effective, and ethically sound, prioritizing the patient's well-being and optimal growth and development. Question 20. When evaluating an infant in the neonatal intensive care unit receiving continuous enteral feeds, and the infant begins to exhibit increased abdominal distension, decreased bowel sounds, and occasional emesis, what is the most appropriate immediate management strategy? Option A. Continue the prescribed feeding rate while closely monitoring for further changes and document all findings. Option B. Administer a prokinetic agent as per protocol and continue the current feeding rate. Option C. Immediately halt all enteral feeds and notify the medical team for a complete gastrointestinal assessment. Option D. Reduce the feeding rate by 50% and reassess tolerance in 4 hours, documenting the changes. The correct answer is A. Continue the prescribed feeding rate while closely monitoring for further changes and document all findings. Explanation. The scenario presents a common challenge in pediatric enteral nutrition, managing a critically ill infant with fluctuating gastrointestinal tolerance. The professional challenge lies in balancing the need for adequate nutrition to support growth and recovery with the risk of complications like abdominal distension, mesis, and feeding intolerance, all while adhering to best practices and regulatory guidelines. This requires a nuanced approach that prioritizes patient safety and evidence-based interventions. The correct approach represents best professional practice because it involves a systematic, individualized assessment of the infant's tolerance to enteral feeds. This includes regular monitoring of key indicators such as abdominal girth, bowel sounds, residuals, and stool output. Crucially, it emphasizes a proactive and collaborative strategy, involving prompt communication with the medical team to adjust the feeding regimen based on objective findings and clinical judgment. This aligns with the ethical imperative to provide competent and compassionate care, ensuring the infant receives optimal nutrition while minimizing risks. Regulatory frameworks for pediatric nutrition specialists emphasize patient-centered care, evidence-based practice, and interdisciplinary collaboration, all of which are embodied in this approach. An incorrect approach that focuses solely on maintaining a prescribed feeding rate without reassessing tolerance ignores the dynamic nature of a critically ill infant's condition. This could lead to the accumulation of unabsorbed formula, increasing the risk of gastrointestinal complications, which is a failure to adhere to the principle of patient safety and could be considered a deviation from best practice standards of care. Another incorrect approach that involves delaying or withholding feeds based on subjective parental concerns without objective clinical data can lead to inadequate nutrient delivery, potentially hindering the infant's recovery and growth. This fails to uphold the professional responsibility to provide evidence-based nutritional support and can negatively impact patient outcomes. A further incorrect approach that relies on a standardized protocol for all infants regardless of individual tolerance overlooks the unique physiological needs and responses of each child. This lack of personalization can result in suboptimal care and increased risk of adverse events, failing to meet the standards of individualized patient care expected in specialized pediatric nutrition. The professional decision-making process for similar situations should involve a continuous cycle of assessment, intervention, and reassessment. Professionals must be adept at interpreting clinical signs and symptoms, understanding the pathophysiology of gastrointestinal intolerance, and applying evidence-based guidelines for enteral nutrition management. Open communication with the healthcare team, including physicians, nurses, and other allied health professionals, is paramount. Documentation of all assessments, interventions, and outcomes is essential for continuity of care and accountability. Adherence to professional codes of ethics and relevant regulatory guidelines ensures that care is delivered safely, effectively, and ethically.